All right, thank you guys. It's so nice to meet everyone. I am getting over a cold, so if I pause to cough or anything, I apologize in advance. But thank you so much. Closer. Okay. Can people hear me okay? Okay, good. All right, so I'll be talking about non-motor symptoms of Parkinson's disease today. So when we think about Parkinson's, you can kind of think of it as a large iceberg where think of the motor symptoms, so like tremor, the difficulty walking, slowness, stiffness. But underneath all of that are all of the non-motor symptoms of Parkinson's, and you can see there's quite a few here. So I'm going to try to touch on most of these, but it's hard to get through every single one in detail. But so the non-motor symptoms of Parkinson's, they're often under-recognized and under-treated. And in many cases, they can be more disabling than the motor symptoms. And as we go through these slides, it's important to keep note that not every single person gets every single symptom. So don't, be concerned that, oh, I'm going to get every single one of these symptoms. This is just for education of things that could happen. So one that can happen is smell and taste dysfunction. So hyposmia or anosmia, that means reduced or loss of sense of smell. This can actually happen years before the first motor symptoms of Parkinson's disease. That can kind of be a clue that maybe that's what we're looking at. Of course, it's a little bit harder now in the day of COVID because people can lose their sense of smell from that. It can lead to decreased appetite because if your smell is off, then your taste is off. Unfortunately, there's no treatment for this one though. Drooling is another very common symptom. And it's not actually due to the overproduction of saliva. It's actually because of impaired mouth movements and swallowing. So the saliva kind of builds up in your mouth. And so that can be bothersome for some people. For some people, it's very mild and doesn't really cause issues. So in the first stages, if it's really mild, it might just be during sleep or with meals, but it can progress to be almost near constant. Louder, okay. All right. Some treatments. So one of the easiest things to do is just sucking on sugar-free candies or chewing sugar-free gum. This just kind of reminds your body to swallow more to get that drool down. Is there some feedback?
Yeah.
Okay. Medications that we can try are atropine drops under the tongue. And we can also do Botox injections into the saliva glands, and that can be quite helpful. Another very common symptom is rhinorrhea, which is a fancy way to say runny nose. So for some people, it can be near constant, almost like a leaky faucet. Obviously, that can be kind of embarrassing or annoying. But this can be treated with nasal spray, so there are options for that. A really big important one is choking and swallowing difficulty. This is because of slowness of movement of the mouth and the throat muscles. So you may notice, or people may notice that when they're eating or drinking food or liquid, if they're coughing a lot or they're choking on it. And this is important to note because it can lead to malnutrition, or if it goes down the wrong pipe, it can get into your lungs and cause what's called aspiration pneumonia. So this is one thing that you definitely want to let your doctor know as soon as possible, because this can be screened for with a swallow study, and you can meet with a speech therapist to work on different techniques to help with that. Obviously, a speech therapist would be able to go over this in way more detail, but a few things that you can do would be taking very small bites and sips instead of taking a really big bite. Take a sip of water after every bite of food. Make sure you're sitting upright when you're eating, so no eating or drinking in bed, things like that. And try not to eat while distracted. So eat at the dinner table instead of in front of the TV or something like that. Nausea and vomiting can also be very common in Parkinson's. It can be a side effect of the medications that we use for Parkinson's. Usually this gets better with time though. And I know for me, I tend to start medications kind of low and slow to try to help with any potential side effects like nausea.
However, it can also occur without medication or apart from medication, and this is because of slowed emptying of the stomach that can occur with Parkinson's. So some things to help with that. So instead of eating a really big, large meal, eat smaller, more frequent meals. There are medications that can be used for nausea. One word of caution is that several medications that are out there that treat nausea can block dopamine and can make Parkinson's symptoms worse. So medications you'd want to avoid would be Reglan, Compazine, and Phenergan, and I put the common names in parentheses next to them. It's probably easier to remember the one that's okay to use, and that's Zofran. That's okay to use in Parkinson's because that does not block dopamine. And if the nausea is a side effect of the medication, there are other medications that we can try to help with that. Constipation is also extremely common in Parkinson's. Similar to the reduced sense of smell, this can be one of the very first signs of Parkinson's, even before you get any of the motor symptoms. So constipation is defined as fewer than 3 bowel movements per week, or if you're having straining to pass stools. And this is because of slow transit in the bowels related to Parkinson's. So the first thing, if somebody told me they were struggling with constipation, the first thing I would talk to them about would be exercise and diet. So making sure you're drinking plenty of water. The goal, I usually give this around 64 ounces of water per day. And making sure that you're increasing fiber in your diet. So things like bran, prunes, and I put a nice little chart in there with some other foods that are high in fiber as well. Making sure that you're exercising regularly can be really helpful as well because that kind of gets the bowels moving. And if those lifestyle changes, increasing water, fiber, if those don't work, we have several medication options that we can do. So there's different categories of medications. So the first one are bulking agents, and these essentially just add fiber to the stool. So if you're not able to get enough fiber in your diet, these can be helpful. And you want to make sure that you're getting enough water with the fiber, because if you don't get enough water, the fiber is not really going to help. So Metamucil would be a common example of that. There are stool softeners. Ollesch or Docusate is a common example of that. And that just kind of helps soften up the stool so it's a little bit easier to pass. There are two different kinds of laxatives. There are osmotic laxatives. So what these do is they increase water retention in the stool to make it easier to pass the stool. And the most common one would be Miralax. And I put a little star next to it just because that's usually the first one I'm going to recommend because it's easy, you can buy it over the counter, and it's very safe. In addition to osmotic laxatives, there are stimulant laxatives. And these stimulate the muscles in the intestine. So a couple examples of that would be Dopalax and Senecot. And then in really severe cases, we can even use suppositories or enemas. But we obviously want to save those for more severe cases. It's not very comfortable. All right, bladder dysfunction is also very common in Parkinson's. So it can lead to urgency, feeling like you got to get to the bathroom right away. Going to the bathroom more frequently. It can even cause incontinence where you can't hold in the urine. And it can cause nocturia, which is a way to say increased urination during the night. So you have to wake up frequently to go to the bathroom. And then in particular, this can be confused for prostate issues. So I usually recommend making sure that you're also seeing your primary care just to get screened for any prostate issues. Some different options for treatment. So avoiding caffeine can help because that's a diuretic, so it's going to make you have to go to the bathroom more frequently. And then restricting water just before bedtime. Obviously, for other reasons, we want to make sure we're getting plenty of water during the day, but restricting it for an hour or two before bedtime can be helpful. Two medications that I would typically use would be Myrbetriq or Gentessa, and that's because there are several other medications that can be used to treat urinary symptoms in general, but those can often worsen cognitive trouble. And so we like to be really careful about that in Parkinson's. There's also DDAVP, another name for that is desmopressin. That can be used more just for urination during the night. And If those options don't work at this point, we're probably considering a referral to urology to see if any like Botox or something like teal nerve stimulation might be helpful. Pain is another big one that's also very common. So this can be directly related to Parkinson's, but I also like to keep in mind that there can be lots of other causes. So arthritis will be a very common cause of joint pain. So we want to make sure we're doing our best to figure out what's really the cause of pain. If it's directly related to Parkinson's, it can cause things like stiffness, cramping, muscle spasms, and it can often be in the neck, the back, and the calves. And another thing that can happen is in some people, when their medications are wearing off, they can get dystonia. So one of the more common types of dystonia is where you get curling of the toes or your foot turns in, and that can be painful. So in general, some things that are really helpful are stretching, massage, warm bath, heating pads, things like that. As long as it's, you don't have kidney problems or liver problems, over-the-counter medications like ibuprofen or Tylenol. If we do think it's directly related to wearing off of your medication, then maybe we need to adjust your Parkinson's medication. And in cases where it is due to dystonia, like that curling of the toes, we can do Botox injections for that. All right. Dementia is also very common in Parkinson's. So up to 80% with Parkinson's will have some type of cognitive trouble during their life. Now that doesn't mean that everybody will have dementia. Some people will have a milder form called mild cognitive impairment, where they have memory issues, but it's not impacting their ability to take care of themselves or function in their day-to-day life. Some things that people with Parkinson's might notice would be slowness of thought, impaired attention and memory, and even visuospatial dysfunction. So issues navigating a space. So a common example is getting lost while driving in a place that's really familiar to you. And this should be screened at least once a year by your doctor. I usually at least ask about memory problems at every appointment. And if I think I had a question from beforehand that was kind of related to how do I know when it's old age versus Parkinson's? The best way to know is to talk to your doctor. And in clinic, we can do a memory test. It's called a MOCA. It's maybe some of you have done it, but it's a shorter memory test. And that's kind of a screening test, and that can be done in the clinic. And if we want even more detail, we can send you to a longer memory test with a neuropsychologist. And that can help us really figure out what's the pattern of memory loss. And the pattern of the memory loss can give us a clue if it's Parkinson's versus just related to old age. For dementia, so I like to tell my patients that what's good for the heart is good for the brain. So keeping a healthy lifestyle is really important for prevention of dementia. So things like exercise, so that's physical activity, and also staying mentally stimulated. So, reading, staying engaged, things like that. Social activity is really important as well. So make sure that you're being social and a part of maybe support groups or have good friendships around you. Healthy diet. So the Mediterranean diet or the MIND diet are two that I typically talk about. In general, it's about kind of limiting red meats and fats and increasing fruits, vegetables, things like that. And then making sure you're working with your primary care to control other things like your blood pressure, diabetes, or high cholesterol. Sometimes certain medications can contribute to thinking and memory problems, so we always want to make sure we're taking a look at that. And then medications that can help with dementia and Parkinson's would be things like donepezil, ribostygmine, and memantine. These don't, I usually tell my patients they're not like a miracle drug. It's not like you take it and all of a sudden your memory is like you're 20 years old. The thought with these medications is that it helps more slow the progression over time. Psychosis can also occur in Parkinson's. So this is hallucinations, so seeing or hearing things that aren't actually there. Illusions, so an example would be there's a coat rack in your room and you mistake it for a person, that would be an illusion. Or delusions. So delusions are fixed false beliefs. So you may believe that your neighbor is out to get you, even though they're clearly not. So that would be an example of a delusion. These are much more common if dementia is present. And this can also be a side effect of medications or due to a medical illness, especially if it comes on all of a sudden. In those cases, you want to make sure you're looking for other causes, like is there an infection that's kind of bringing this out. So as far as treatment, so one of the first things, like I mentioned, especially if it's very sudden onset, we want to look for medical illnesses. So like a urinary tract infection, we want to check for pneumonia, even things like severe constipation can kind of trigger this. And talking with your doctor to see if there's any medications that could be contributing and see if those medications need to be stopped. Sometimes we need to adjust the Parkinson's medications, especially for medications like amantadine, trimethoprim, or if you're on any dopamine agonists, that can contribute. Treatments for it. Treatments for psychosis would be antipsychotics, but there's only 3 that are considered safe in Parkinson's. So pimavanserin, clozapine, and quetiapine. The one I use most commonly is, to start with, would be quetiapine. And that's only because pimavanserin is newer, so it can be a little bit more expensive. And clozapine has, in the past, historically required pretty frequent lab monitoring. Although I've heard that they've loosened up on those requirements. Do not use any medications like haloperidol, risperidol, or olanzapine. These are antipsychotic medications that can worsen Parkinson's, so we want to be careful about those. Depression is also very common in Parkinson's. And this is actually related to the underlying disease. It's not just a reaction to getting or having the diagnosis of Parkinson's. And it can be a very early sign of Parkinson's as well, even before you get those motor symptoms. Things that are helpful for depression would be cognitive behavioral therapy, so speaking with a counselor and working on different techniques to help with depressive thoughts. Exercise, I'm really going to harp on that one today. And medications, we use those quite a bit. So there's different classes. There's SSRIs and NRIs. Those are the most common that we use. So these are selective serotonin reuptake inhibitors. So they increase the amount of serotonin that's available. And SNRIs are serotonin and norepinephrine reuptake inhibitors. So those increase both serotonin and norepinephrine. And these are chemicals that are helpful for mood. So these are not all of the examples that you can use, but some common ones would be citalopram, escitalopram, sertraline, venlafaxine. I often use Cymbalta, especially if there's pain as well. I typically try to avoid tricyclic antidepressants. So an example of that would be like amitriptyline and paroxetine. And that's because these medications can work on, they can affect the cholinergic system, and acetylcholine is important for memory and cognition. So because these medications can affect that, it can worsen cognitive issues. Anxiety can occur as well, and this often occurs with depression. So it's very common that people have both anxiety and depression. This can lead to panic attacks, phobias, or just more of a generalized anxiety, just kind of constantly feeling keyed up all the time, or constant worrying. And similar to depression, this can be a symptom that can occur very early on in Parkinson's, and in some cases before the motor symptoms start. Anxiety in particular can also sometimes be due to wearing off of medications. So if you notice that half an hour before your next dose of medication, you're always anxious, that could be a sign that it's related to wearing off. So if we think it's related to wearing off, then that's a case where we might address your Parkinson's medication. If it's more generalized and not clearly due to wearing off, Oftentimes we use those same medications that we use in depression. Other things like mindfulness, meditation, speaking with a counselor or a therapist can also be helpful. Apathy is common as well, and this one can be a little bit tricky. So this is kind of, I would describe it as a lack of interest, initiative, motivation. So just, maybe you used to really enjoy doing certain activities, and now you just really don't have the motivation to do that. Or kind of indifferent, not having goals for the future, and not enjoying your favorite activities that you used to. This one can be really tricky to treat. If it occurs with depression, then we may use medications, those same antidepressant medications. But sometimes it's separate from depression. Exercise has been shown to have some benefit for apathy. And one thing I tell my patients is schedule activities that you like so that it's on the books and you have to go. And then usually once you get there, people really enjoy it. Whereas if you leave it to the last minute to decide if you want to go or not, you're more likely to just decide to stay home. I wanted to talk a little bit about impulse control disorders as well. So this is not directly from Parkinson's, but this is something that can happen because of the medications we use to treat Parkinson's. So this can be an increase in compulsive or impulsive behaviors. So examples would be excessive shopping, running up credit cards, going into debt, gambling, binge eating, cleaning excessively, hypersexuality. Funding is another form of that, where it's just kind of this repetition of useless tasks. So I think one example would be, I heard about a patient who would constantly take apart and put back together clocks or things like that. And this most commonly happens with dopamine agonists. So an example of a dopamine agonist would be something like pramipexole. It technically can happen with the more common medication of carbidopa-levodopa or the brand name of Sinemet, but it's much less likely. Dopamine dysregulation syndrome can also occur. This is an addiction to Sinemet or carbidopa-levodopa, where you're constantly taking more and more pills, even though your symptoms of Parkinson's are pretty well controlled. So that I haven't seen that too much, but it is something that we always keep in mind and make sure we're watching for. Sexual dysfunction is quite common as well. So things like erectile dysfunction, reduced libido, and difficulty reaching orgasm. And then like we just spoke about with those medications, a side effect can be that hypersexuality or inappropriate sexual behavior. Again, that's usually due to those dopamine agonists. And we see this a lot more in men compared to women. So if it's erectile dysfunction, treatments for that might be Viagra or Cialis. If it's that hypersexuality, we would reduce or stop the medications that we think are contributing. And oftentimes this might be something where we consider a referral to urology for some help. So orthostatic hypotension is very common. So this is a drop in blood pressure that occurs, especially when you're changing positions. So, going from laying in the bed to standing up. It can also occur after large meals because all the blood kind of rushes to your stomach. And so your blood pressure throughout your body kind of lowers. The most common symptoms are the ones that people are most familiar with are things like lightheadedness or passing out or dizziness is how some people describe it. I emphasize these other ones like shoulder aching. That's called a coat hanger syndrome, where you get pain throughout the shoulders, and cognitive slowing, because those, I think people don't always immediately recognize that can be due to drops in blood pressure, but those are still things that we want to be looking out for. So if somebody is struggling with orthostatic hypotension, and one way that we screen for this in clinic is we check your blood pressure while you're laying down and have you stand up for a few minutes and then we recheck it. The first thing that I would recommend is, again, increasing that water intake. So the same goal of around 64 ounces if you can. and increasing salt intake. So I see this a lot that maybe in the past somebody struggled with high blood pressure, and so their doctors had them on blood pressure medications to lower it and told them to avoid salt. But then when their Parkinson's gets worse, suddenly their blood pressure is lower, and we're telling them the opposite. And that's because we're dealing with a different problem. And sometimes people who require blood pressure medications in the past need to come off of those when their Parkinson's progresses, because now instead of high blood pressure, they're struggling with low blood pressure. Smaller, more frequent meals can be helpful because, again, if you eat a really big meal, all the blood kind of rushes to your stomach. And so focusing on those smaller meals instead of a really big meal. Elevating the head of the bed to at least 30 degrees can be quite helpful. And this is more to help first thing in the morning so that you're not getting such severe drops in blood pressure first thing in the morning when you're getting out of bed. Compression stockings can be helpful. The major issue is that the compression stockings that only go to your knees probably aren't going to work. For compression stockings to work, they have to go up to the middle of your thigh or higher. And that's because when you go from laying to standing, most of the blood kind of pools in your abdomen area or the top of your thighs. So you're always welcome to try those compression stockings that go to the knees, but typically they don't give much benefit. Being more careful about changing positions can be really helpful as well. So instead of just going straight from laying in bed to standing right away, doing things like getting up a little bit more slowly, sitting at the edge of the bed for a few minutes and giving your body time to adjust can be really helpful. And making sure that, again, we're going to harp on exercise a lot today. Obviously, if people have drops in blood pressure, certain exercises can be really difficult. So one that can be helpful is if you have a recumbent bike, because you're not standing straight upright. Pool exercises can be helpful too, because some of that pressure from the water helps with that drop in blood pressure. If changes in diet and lifestyle changes don't work, we also we do have medications that we can use. The most common ones are going to be these three, which include Midodrine, Florinef, and Northera. And one thing to keep in mind, if we start medications for low blood pressure, we also want to make sure we're screening for high blood pressure, especially when laying down. So usually these medications, I say don't take before bed. Take the last dose several hours before bed. Fatigue is almost universal in Parkinson's and can be really debilitating for some people. This is a lack of energy, just feeling drained, and it's different from sleepiness or just needing a nap. It's, I'm not sleepy, but I just feel overall tired and fatigued. This one, unfortunately, can be really tricky to treat. One thing, so we want to make sure it's not due to other causes. So making sure it's not due to low blood pressure, for example, or is trying to figure out, is it actually more sleepiness rather than fatigue? Exercise can be helpful. It can be hard because the fatigue can make it difficult to get started. But once you get that exercise in, oftentimes it'll increase your energy after exercise. So starting small can be helpful. Sometimes we can adjust the Parkinson's medications if I think it might be related to that. So Legiline is a medication that is used primarily to help extend how long medications like carbidopa, levodopa are lasting. But a side effect of it is it can be kind of activating. So sometimes I'll use that to my benefit. Short naps, less than 20 to 30 minutes, can be really helpful and give people kind of a boost of energy. And if all of that doesn't work, sometimes we'll consider medications like modafinil is a common one. Provigil is the other name for that. And in rare cases, stimulants, but we want to make sure we're being careful with those because they can have a side effect of worsening cardiac issues if that's a problem. Excessive daytime sleepiness is also common. And again, this is different than just fatigue. This is things like falling asleep in the middle of the day, during meals, or if you're just sitting in a chair. Dopamine agonists, so like the pramipexole that I mentioned before, that can actually lead to sleep attacks where you just very suddenly fall asleep. And then we also want to make sure that even though excessive sleepiness can be related to Parkinson's, that it's not related to something else like sleep apnea. So it's not uncommon for me to recommend a sleep study to make sure that we're not missing something else. So I'm just going to get a coffee. So some treatments for that are being in a stimulating environment, getting exposure to bright light, easier in Colorado, although today's kind of a cloudy day. Exercise, again, can be really helpful. Caffeine, of course, you don't want to overdo it because if there's too much caffeine, that can increase irritation. Short naps, so less than in 1 hour. Ideal would be 20 to 30 minutes, and just one per day, not napping 8, 10 times a day or something like that. Taking a look at that medication list. Are we on dopamine agonists? Do we need to come off of those? And same thing, if all of that doesn't work, in some cases we'll consider medication as a treatment. It's those same medications. On the opposite end, insomnia is often very common. So there can be trouble getting to sleep as well as trouble staying asleep. So you fall asleep just fine, but you're waking up throughout the night multiple times. Sometimes waking up too early, and then you can't fall back asleep. And this is because in Parkinson's, there's a disrupted circadian rhythm, and your sleep-wake cycles are thrown off. So some things that can help. So the first thing I talk about is sleep hygiene. So trying to force yourself to go to sleep and wake up at the same time every day. Avoiding daytime naps. So again, this is one of those where if you're struggling with fatigue, then a short nap might be helpful. But if you're struggling with insomnia in the night, then I'd probably say, okay, let's not nap during the day so that we can try to get you to sleep at night. Keep in mind, the bedroom is for sleep and intimacy only. Don't be watching TV in your bed or scrolling through your phone. I'm guilty of that, so. But those activities can be very stimulating. And one thing I tell people is if you're laying in bed and you just can't fall asleep, if you do that for too long, you start to associate your bed with not sleep, and we don't want to create that association. So I often tell my patients, if you're struggling to fall asleep, get up out of bed, go to a different room and do something relaxing. And that would be something like reading a book or doing a puzzle. I try to avoid telling patients to just go to a different room and watch TV or play on their phone or something, because again, screens can be kind of activating. Exercising during the day can also help us sleep at night, and avoiding caffeine late in the evening or in the late afternoon. Same thing, we want to check for medications that could be making this worse. So like I said, selegiline can be kind of activating, so sometimes we use that to our advantage. But if we're struggling with insomnia, then maybe we need to come off of it. Medications that are very helpful, the first one I often tell patients is melatonin. This is very safe, you can buy it over the counter, and there's a wide range of doses that you can try. I usually tell people to just start with 3 milligrams. They do sell 1 milligram tablets. If you're somebody who's really sensitive to medication, it's fine to try that. But in general, I find that most people need at least 3 milligrams. And this is safe to take up to 12 to 15 milligrams. I usually say after that, though, it's probably not, you're probably not going to get much more benefit. So I usually say, let's move on to something else. If your Parkinson's symptoms are waking up in the middle of the night, sometimes we'll add a nighttime Cinnamon dose, the controlled release version. Trazodone is a medication that I use a lot. In general, I recommend avoiding medications like Ambien because this can worsen balance and worsen cognitive issues. So REM behavior disorder, or RBD, this is the acting out of dreams at night. And this can happen even before those motor symptoms of Parkinson's. So sometimes if you're coming in and we're trying to figure out a diagnosis, this is another symptom I might ask about if you had in the past. This can include talking, screaming, kicking, punching, and this can be quite disruptive. So it can lead to safety concerns. So I've had people tell me they've fallen off the bed, or they've hit their bedside table and injured their hand. And sometimes it can be really disruptive for your bed partner because you're hitting them in the middle of the night. So the first thing I always talk about is bed safety. So moving sharp objects like a bedside table away from your bed. So this is an example of, I would say, okay, get those bedside tables farther away from your bed. Placing pillows or mats on the floor so that in case if you do fall out, you're less likely to be injured. Having bed rails to keep you from falling out of bed in the first place. And even moving your bed closer to the ground. Medications, so there's really two that we use. The first one being melatonin again, because that one's very safe, easy, cheap. And sometimes we have to try a low dose of clonazepam to help with acting out of dreams if melatonin isn't working. But in some people, this can lead to sleepiness during the day. So restless leg syndrome is something that can happen, it's quite common with Parkinson's. It can also happen in people who don't have Parkinson's. But this is an uncomfortable sensation in your legs when you're laying in bed trying to get to sleep. It can, people describe it differently, but some things I've heard is a creepy crawly feeling, tingling, bugs on your legs. And this is often relieved by moving your legs around. So getting up, stretching, walking around. And this can be worse in the evenings, or it's often worse in the evenings, especially in the beginning. But if it's been going on for a long time, it can move into the daytime as well. So the first thing to do would be to check iron levels because low iron can make restless leg symptoms worse. And sometimes just starting iron supplementation can help the symptoms quite a bit. If that doesn't work, medications that I'm most likely to use would be things like gabapentin or pregabalin. The brand name of that one is Lyrica. All right, so that was a whirlwind of symptoms. But if you only took away a few things, I would keep in mind that Parkinson's disease affects way more than just movement. So we always focus a lot on the movement symptoms because that's how we diagnose Parkinson's. But as you can see, there's a lot of other things it affects. Being aware of these symptoms makes it easier to recognize, which makes it easier to find treatments that can help you. And every person with Parkinson's is different. So again, just reiterating that not every person is going to get every single one of these symptoms. So if there's one thing you could do for yourself right now, I'm going to harp on exercise again to make sure that this point gets driven home. There have been studies that actually show exercise can help slow the progression of Parkinson's. We don't have any medications that do that. It can help prevent dementia. So we talked about, remember what's good for the heart is good for the brain. And I give a goal of 30 minutes a day, 5 times a week, or 150 minutes throughout the week. And you can change how you spread that out. But really, anything is better than nothing. People often ask me, what is the best exercise to do? We don't have enough research to tell you the best exercise. So what I tell patients is find what you like, because if you like what you do, you're more likely to keep it up. Some common things would be cycling, walking. PAR has a lot of exercise groups I know that you can join. Boxing is a popular one. Ping pong has been popular as well. So there's all sorts of different activities you can do. So I did receive some questions beforehand that I wanted to address. The majority of them, I think, were addressed during the presentation, but there were a few that didn't quite fit in, so I wanted to give them their own slide. So there were several questions about deep brain stimulation. So again, it's not the focus of the presentation, but I did want to touch on that today. So generally, it does not improve any of those non-motor symptoms that we talked about today. It does help with those motor symptoms, so the tremor, the slowness or bradykinesia, the stiffness or rigidity. It can help with dyskinesias, those wiggling movements, like if you've ever seen Michael J. Fox. And it can help with motor fluctuations. So people who would be good candidates for deep brain stimulation are those that have had a good response to medication. And we'll test that in the clinic just to prove to ourselves that you do have good response to medication. People who have a lot of motor fluctuations, so lots of, maybe they have a lot of dyskinesias when they're on, but then they have a lot of off time as well. So they're just kind of up and down throughout the day. And despite optimizing medications, we always want to see what we can do with medications first. And in cases where people have tremor that's not responding to medication, tremor is one of those symptoms that can actually you can get a better response with DBS than just medication. Reasons that we would not do DBS is if somebody had dementia, or if they had severe or uncontrolled depression, anxiety, or psychosis. And there are several different reasons for that, but there's a risk that with the surgery that we can worsen thinking and memory, and there are some cases where depression or anxiety can get worse. So we want to make sure that if you have those symptoms of depression or anxiety, that we're getting them controlled before we get you to surgery. There was one question about medical aid in dying. This is legal in the state of Colorado. This is for terminally ill patients. People have to have a prognosis of 6 months or less. They have to be mentally capable of making their own healthcare decisions. So obviously that can get tricky if someone has really bad dementia, for example. They have to be able to administer and ingest the drug themselves. And to be honest, the best resource, if this is something you are really interested in, we have a neuropalliative care clinic at the University of Colorado. Those would be the best people to talk to. And I didn't put an extra slide for this, but I think another question was about vision changes with Parkinson's. So common ones would be you can get double vision, especially if you're doing something close up like reading. And that's because your eyes can have a hard time. It's called convergence, where they come together when you bring objects closer. And in Parkinson's, sometimes that ability for the eyes to come together is impaired. And blurry vision can also be common in Parkinson's. That can be related to dry eye. And that's because oftentimes in Parkinson's, you're not blinking as much. So if it's dry eye, a very common treatment would be just eye drops. If it is that convergence insufficiency, sometimes special glasses called prisms can be helpful. And I think there was one other question about changes in heat or cold tolerance. So that is another thing that can happen with Parkinson's, and that's related. So your autonomic nervous system is kind of your fight or flight system. And that controls your blood pressure, your bowels, your bladder. So that's why it can cause all those problems. And another thing it controls is your sweating response. And so sometimes there can be sweating abnormalities in Parkinson's, and that can make it harder to tolerate heat or cold. All right, so we have time if anybody in the audience has questions. Yes, I saw you first with the glasses.
So your comment about heat regulation, the last comment you made, or do you have any ideas what people can do if they have that symptom?
Yeah, that's a good question. So, sorry. So the question was, what can we do if there are those changes in sweat patterns? So a lot of times people with Parkinson's, they don't sweat as much, so they can't cool off as well when it's really hot out. So making sure to be careful if you're going to be in a warm environment, limit your time in the heat, make sure you bring plenty of water, having things like cooling like neck cooling objects or fans, things like that can be quite helpful. Yes, yeah.
Following on that question. Notice I take Cinnamon, about 10 to 15 minutes later, I feel like they're flushed. They sort of a hot flash that lasts for 5 or 10 minutes, and see that it goes away. Have you heard anything like that related to heat tolerance issues?
I actually did have a patient recently tell me they had something similar. In their case, what we did is we tried a different formulation of Cinnamon, and that helped a little bit for them. So that is something that I have heard about before. Yes. I'm sorry. The question was, he notices that he'll have flushing or excessive sweating after taking his Cinnamon or carbidopa. And my response was, I have heard of that before from a patient recently, and in their case, it was helpful to change the formulation of their medication. Yeah.
This hypotension, this having low blood pressure consistently versus orthostatic hypotension, which occurs when you change your posture. And are those treated the same? And is this a low blood pressure of one of the symptoms of Parkinson's in general?
So the question was about low blood pressure in general versus orthostatic hypotension, or those drops in blood pressures. We do see both, and in both cases, so a low blood pressure is just kind of your blood pressure is kind of consistently low, but there's no major changes when you go from laying to standing. I see that a lot of people are not staying well hydrated, or maybe they're on those blood pressure medication to lower their blood pressure because they used to need it. And then orthostatic hypotension is more, you may have a normal blood pressure when you're just sitting there, but as soon as you stand up, it drops quite a bit. In both cases, if we're not able to control it with diet, increasing water, in both cases, we can use medication to help raise up that blood pressure. And they can both have similar symptoms. Yes.
So we talked about the stem cell transplant into Parkinson's patients, and apparently they're after 18 months showing no progression, and their symptoms in some cases haven't heard anything about that.
That's a good question. I'm less familiar with that study. I believe they're thinking about or trying to recruit patients at the University of Colorado for that. It may be a different study, but looking at stem cell, I would say in terms of stem cell treatment, we're still in the early phases of research, so we don't know enough to say that we recommend it quite yet. And 12 patients is a pretty small group, but it's exciting, and we'll keep an eye out for that. Yes.
I can make some comment on the stem cells. Those are two small studies, one in Japan, one in the US, 8 people and 10 people. They have no progression, but we are very ignorant about the destiny of the stem cells. So are they associated with cancer? We still do not know. So there are many questions about that. But we do have some stem cells in our brain. We do. So the doctor was always reporting out exercising capital letters, exercise, that's how she reported, capital letters. So through exercise, we can stimulate the little portion of our brain may eventually produce very specific cells. So there are those stem cells that we have. This area keeps shrinking while we age, but through exercise, we can stimulate it.
Thank you. Yes, I saw your hand first.
This is a question from the care partner perspective. There's so many interrelated symptoms in the patient. It's like it's a challenge for care partners to manage complex cases.
So the question was from a care partner perspective. It can be really confusing what's due to medications, what's due to Parkinson's, and any tips to kind of help with that. So I'll give an example. So sometimes, so we tell you guys to keep track of your symptoms and tell us when does the medication work, when does it wear off. And sometimes people take that really seriously. They're watching every single symptom and they're documenting everything. Then it's almost like too much information. So what I say is Parkinson's is difficult because every day is different. You guys probably have experience with that. What's most important are those trends. So if after you started medication in general, memory's been worse for quite some time, okay, well, that's important to know. But keeping track of every tiny fluctuation every single minute of the day, that doesn't necessarily, if you were sleepy one day, that doesn't necessarily mean that that's something that we have to make a change about. It's those trends that are most important. I hope that's helpful. I think I saw you with the green in the back. I hope I heard you, but I think the question was about speech difficulties in Parkinson's. Is that correct? Okay. Or the Parkinsonian syndromes, yeah. So all of them can be similar in the fact that your speech, your voice can be quieter, softer. People may be asking you to speak up more frequently. Sometimes speech can get more slurred or just harder to understand. I've heard people describe their speech as mumbly. That's another one. So typically for that, that would be a time that I would say, let's go talk to a speech therapist. And if we can, find one that specializes in Parkinson's or at least knows about Parkinson's, because they'll work with you for different exercises to help improve the volume of your voice. And then I think I saw some hands over here. Sorry, I don't know who to, let's do a striped shirt first. Yeah, that's a great question. So I would say two things that I'm really excited about. They're actually here today, which is nice. So in deep brain stimulation, adaptive DBS is now approved. We're still early in the learning process of that, but it's definitely really exciting. Another thing that I think is very exciting is we now have two different options for, it's a subcutaneous pump that can deliver levodopa on a continuous basis rather than having to take pills. Because when you take a pill, the levels kind of spike up and then come down. So the thought with this is it kind of gives it a more even distribution. So those two things are pretty exciting, I think. Yes.
To produce dopamine agonists. Can you explain what those are a little better?
Yeah. So the question was about dopamine agonists and explain what those are. So in Parkinson's, probably the most common medication we use is carbidopa-levodopa, and the levodopa portion of that goes into the brain where it's converted to dopamine and then acts on the dopamine receptors. And this is because in Parkinson's, dopamine levels are reduced. Dopamine agonists work directly on those dopamine receptors. So they're different than the carbidopa-levodopa. So some examples of that would be ropinirole, pramipexole, and we still use them. And if you're tolerating them fine, we don't necessarily need to change them, but they are a class of medication that are more likely to lead to some of those side effects. So maybe one that needs to be changed, depending on the person. Yes. The question was about the PDQ DNA study at Indiana University. I'm not familiar with that one in particular. I know there's a study called PD generation that we're taking part of at the University of Colorado, where we're identifying different, so you can get free genetic testing and we're collecting information about that. Is it the same one? Okay, gotcha. Yes.
More about what the effects of Botox and how that's and how that works.
So the question was about pain, especially related to toe punching, so dystonia and how Botox works. So Botox is a medication. So there's different formulations. Botox is the brand name of one of them, but there's other ones like Xeomin, Myoblock. There's different formulations, but so essentially what it does is it helps weaken the muscles, and we're using that to our advantage because when you're having things like that toe curling or clenching, your muscles are too active. It involves getting an injection to different muscles, and it kind of depends on what's going on. So if it's toe curling, for example, a common injection would be kind of midway up the calf here and at the bottom of the feet, for example. So it can be a little uncomfortable to get it. Every person's a little bit different, of course, but there are things we can do to help with the uncomfortability about that. And in general, it lasts about 3 months, so it does have to be repeated every 3 months. Yes.
I get
Glad to hear that. Yeah, so a comment from an audience member is that she's been getting Botox and it's made quite a difference for her. Yes.
site and to have the cuts that have been administered to the NIH and major universities who would be focused upon medical research, how that's impacting continued research and efforts, especially in the Parkinson's community.
So the question was about cuts to NIH funding and what's happening with research given those cuts. So my experience is going to be, I'm going to know the most about what's going on at University of Colorado, of course. So we have not stopped any of our studies. They are reallocating funds to try to make sure that we have enough money to continue those studies. Some of the studies have maybe needed to be changed a little bit, but we are still continuing research and we still think it's really important. Yes.
Finding estrogen levels and address that in ways to Parkinson's.
Oh, that's a really good question. The question was about estrogen levels in Parkinson's disease. I'll admit that's something I don't have enough knowledge about. So I don't have a great answer for that one, but that's definitely something I'll try to look into. Oh, gotcha. Yeah, I'll have to take a look at that. Awesome. Oh, another question? Any chance? So the question was about a new drug coming out of the UK. Any chance you recall the name of it or anything about it? Okay. Okay. I'm not entirely sure. The newest, latest drug that I know of is Brexant. If anybody's heard of that medication, it's an extended release version of carbidopa levodopa, kind of like Rytari, if you've heard of that one. So maybe it was about that, but I'm kind of taking a guess. Yes.
It is not, it doesn't quite, no, I adjusted, but it really, 1,500 to the freezing max. Yeah. But you still owe some significant. Good for you. I think it's better but it depends on you.
So there was a comment from the audience about if you don't have Medicare, there may be options to get assistance to pay for Botox through the company itself. And that's kind of a general rule for other things too, including some of those newer medications. In cases where they're not covered, we sometimes there are ways we can find ways to get it covered. So yes.
I was wondering if you can somehow advise or refer folks in this room who deal with multiple choices regarding what to do, whether it's medication, whether it's a provider, or whether it's lifestyle change, how to better holistically in their lives deal with all these choices, particularly as they're getting older, when it's difficult to make choices in our world. Are there any emerging technologies or emerging sensitivities in the medical profession that help folks deal to become more holistic in how they address their symptoms and their health?
So the question, I hope this, let me know if I don't summarize this correctly, but kind of related to there's a lot of different choices and how to go about making those choices in terms of which medication or procedure or even provider to choose. So in terms of choosing medication or if you are a candidate for a procedure, that is definitely something that's going to be a conversation with your doctor. And they can talk to you more specifically, because like we talked about, you know, not every medication is perfect for every person and not every procedure is perfect for every person. Obviously, there's a lot of new things on the horizon. So if you are able to, I think it's always great if you can to see a movement disorder specialist, because we just have more training in Parkinson's disease specifically. I know that that may not be an option for every person, but that would be one thing. As far as choosing a provider, I think, you know, so I think you definitely at a minimum want a neurologist. So neurologist is somebody who's completed a residency in neurology. And different providers are going to have different comfort levels with Parkinson's depending on their residency. And so it may be something that you just ask them when you meet them, how comfortable are you with Parkinson's? And maybe they'll say, you know, not that comfortable, and they'll send a referral. Or maybe they'll say, I'm a general neurologist, but I feel really comfortable with Parkinson's and have good training in it. So that's going to vary a little bit. A movement disorder provider is going to be somebody who did additional training purely focused on movement disorders, especially Parkinson's disease. So they're going to have some additional training with that. And then as far as finding a provider, you know, if you have multiple choices of a movement disorder or a non-movement disorder provider, I would say make sure you pick someone you feel comfortable with, someone you feel like you can ask questions to, and somebody who appears knowledgeable about the disease. And the more knowledge you have yourself, the more you're going to be able to kind of gauge their knowledge base. But yeah, it can definitely be overwhelming because there can be so many choices. But that's where I think it's helpful to have a good relationship with your providers so they can help narrow down some of those choices. Yeah.
Is it good to consider palliative care?
Yeah, so the question was about palliative care. I'm very much so a big fan of palliative care. So some people think of palliative care as purely hospice, like end of life, but we've really expanded what palliative care means. So palliative care, I like to think of it as kind of focusing on making sure that we're improving the quality of your life and focusing on treating symptoms that improve that quality of life. And so, fortunately, at the University of Colorado, there's several neuro palliative care providers, two of which did their fellowships in movement disorders. And I was lucky, I got to rotate through that clinic as part of my training as well. And so, you know, it's something that depending on the provider, maybe just integrated into clinic already, but if it's needing even additional support, then it might be a good idea to get a referral to see a palliative care physician. Yeah, question.
It's so ambiguous that it's kind of lost its meaning. So what we often talk about is what is important to you to live well within the context of your current medical situation, which is a completely different shift. So sometimes those consults you might have one and have a follow-up maybe once or twice, and then you may not see them for another couple of years. But they're really helpful as a touchstone to talk about what the changes are, how they're affecting you, what's important to you, and what medications, treatments that align with your goals, and to really have in-depth risk-benefit discussions so that you feel confident in your plan for where you're going.
Great. We had a comment from a audience member who used to work in palliative care. And just she was kind of reiterating the benefits of it, and that the goal of it is to help you live your best life with whatever medical issue that you have. In this case, we're talking about Parkinson's, but there are other times we use palliative care as well. Yeah.
I would quantify your statement a little bit and say, focus on quality of life as opposed to quantity of life. It seems that most of the medical focus is extending your life as long as possible. And palliative care doesn't care how long you live, it cares how well you're living now.
Yeah, that's a good point. So another comment from an audience member about palliative care is about improving quality of life and not necessarily only focusing on quantity of life. So making sure you're living your best life and not only focusing on years of life. Any more questions? All right, well, I just want to say thank you again so much for having me. This is my little family, so that's my husband and my dog and our 2 cats. We're really excited to be joining the community up here.